Persistent groin pain after total hip arthroplasty, or THA, can be both frustrating and puzzling for patients and clinicians alike. Among the various causes, iliopsoas impingement is increasingly recognized but often overlooked. This condition affects a small percentage of those who undergo hip replacement, yet it can significantly impact quality of life. In this video, we'll explore what iliopsoas impingement is, why it happens, how it's diagnosed, and the best ways to manage it. By understanding this condition, patients and healthcare providers can work together to achieve better outcomes and smoother recoveries. Iliopsoas impingement refers to mechanical irritation of the iliopsoas tendon, usually caused by the components of a hip prosthesis after THA. This irritation often results from factors like interior overhang of the acetabular cup, retained cement, or long screws. The iliopsoas tendon, which plays a crucial role in hip flexion, becomes irritated when it rubs against these structures. Patients typically notice pain that worsens with activities involving hip flexion, such as climbing stairs or rising from a chair. Recognizing this specific cause of pain is essential for effective treatment. Hallmark symptom of iliopsoas impingement is persistent groin pain, especially during activities that require active hip flexion. Patients may find it difficult to climb stairs, get in and out of cars, or even rise from a seated position. Sometimes a snapping or clunking sensation is reported. On examination, passive hip movement is usually pain-free, but active movement, particularly flexion, triggers discomfort. These symptoms can be subtle but are important clues for diagnosis. Iliopsoas muscle group consists of the psoas major and the iliacus. These muscles originate from the lumbar spine and iliac fossa respectively and converge to insert at the lesser trochanter of the femur. Iliopsoas is the main hip flexor and also assists in external rotation. Its tendon passes beneath the inguinal ligament and is separated from the hip joint by the iliopsoas bursa. Understanding this anatomy is key to recognizing how impingement can occur after hip replacement surgery. Anatomic studies have revealed that the iliopsoas tendon complex can vary between individuals. In some, the iliacus fibers stop at the femoral neck, while in others, they continue to the lesser trochanter. The iliopsoas bursa, which separates the tendon from the hip capsule, can become involved if the interior capsule is altered during surgery. These variations can influence both the likelihood and presentation of impingement symptoms. Functionally, the iliopsoas is vital for hip flexion and external rotation, stabilizing the hip joint during movement and posture. The psoas major is innervated by the lumbar plexus, while the iliacus receives its nerve supply from the femoral nerve. Blood supply comes from the internal iliac artery. This muscle group is essential for everyday activities like walking, standing, and climbing stairs, making any impairment particularly impactful. Iliopsoas impingement can develop anytime from 1 month to 8 years after hip replacement, regardless of whether the acetabular component is cemented or not. The pain is often severe and persistent, sometimes requiring patients to use their hands to lift their leg. While walking may not always be painful, activities like resisted hip flexion or straight leg raises can trigger symptoms. Recognizing the timing and triggers of pain helps differentiate iliopsoas impingement from other causes. During a clinical exam, passive hip movements are usually pain-free, but active movements, especially flexion, are limited by pain. A straight leg raise may reproduce symptoms, and tenderness in the groin area is often noted. Rarely a palpable snap or mass may be found if bursitis is present. These findings, while subtle, are important for distinguishing iliopsoas impingement from other hip problems. Imaging is crucial for diagnosing iliopsoas impingement. Standard radiographs, including anteroposterior and cross-stable lateral views, help assess the position of the acetabular component and detect any overhang. If X-rays are inconclusive, CT scans can provide detailed measurements and reveal interior overhang or tendon hypertrophy. These imaging techniques are the first step in confirming the diagnosis and planning further management. Standard imaging doesn't provide clear answers. Advanced techniques like MRI and ultrasound come into play. Modern MRI sequences can reduce metal artifacts, allowing better visualization of the iliopsoas tendon and surrounding tissues. Ultrasound, especially in experienced hands, can show displacement of the tendon and guide diagnostic injections. These tools help differentiate iliopsoas impingement from other causes of groin pain after THA. Key step in confirming iliopsoas impingement is the use of image-guided diagnostic injections. By injecting local anesthetic, sometimes combined with corticosteroid, into the iliopsoas tendon sheath, clinicians can determine if the tendon is the source of pain. Temporary relief following the injection strongly suggests iliopsoas involvement. This approach not only aids diagnosis but can also provide short-term symptom relief. Initial management of iliopsoas impingement focuses on conservative measures. Rest, anti-inflammatory medications, and physical therapy are the mainstays. Stretching and strengthening exercises, especially those targeting hip extension and rotation, are recommended for 6 to 8 weeks. Gait retraining and daily stretching of the hip flexors, buttocks, and hamstring are also important. While these approaches can provide relief, they may not always resolve symptoms completely. Corticosteroid injections into the iliopsoas bursa or tendon can offer temporary relief, lasting from a few months up to a year in some cases. These injections are often guided by imaging to ensure accuracy. While they can help manage symptoms and delay surgery, their long-term effectiveness is inconsistent. Patients should be aware of potential risks such as temporary muscle weakness, but complications are rare. If conservative treatments fail, surgery may be necessary. The most common procedure is iliopsoas tenotomy, which involves releasing the tendon to relieve tension and pain. This can be done through open, percutaneous, or arthroscopic techniques. If imaging shows interior overhang of the acetabular component, revision surgery to reposition the cup may be required. Surgical intervention has a high success rate, with most patients experiencing significant improvement. Surgical management, especially iliopsoas tenotomy or acetabular revision, offers lasting relief for most patients. Studies report success rates above 90% with improved function and reduced pain at follow-up. Arthroscopic techniques tend to have fewer complications compared to open surgery. Early recognition and intervention are key to optimizing recovery and restoring mobility. With advances in surgical techniques and robotic-assisted procedures, outcomes continue to improve for patients with iliopsoas impingement after THA. Iliopsoas impingement is an important but often overlooked cause of groin pain after total hip arthroplasty. Diagnosis requires careful clinical assessment and targeted imaging. While conservative treatments and injections may provide temporary relief, surgical management is often needed for lasting results. Early recognition and a structured approach to diagnosis and treatment are essential for improving patient outcomes and quality of life. Advances in surgical techniques and robotic assistance are helping to further reduce complications and enhance recovery.